I want to tell you about a woman who came into my neurology clinic convinced she was losing her mind. She was 72, sharp her whole life, retired teacher, avid reader, the kind of person who remembered everyone's birthday without a calendar. But over the past year, names had started slipping. She'd walk into a room and forget why. Mornings felt foggy in a way she couldn't shake. Her daughter had started researching memory care facilities. When I reviewed her medications, I found 3 of them. None were prescribed for her brain. One was from the grocery store sleep aisle. One was for her bladder. One was something her doctor had started years ago for anxiety and simply never stopped. Within 6 weeks of carefully reducing those medications, she called my office and said, "I feel like myself again." She didn't have Alzheimer's. She had chemistry working against her. And the reason I'm making this video is because she is not unusual. In my neurology clinic, I see this pattern regularly. People who have accepted cognitive decline as their new reality, when what they actually have is a medication problem with a real solution. Today, we are going through the specific medications most likely sitting in your cabinet right now, what they're doing inside your brain, and what you can do about it. To understand why these medications are dangerous, you first need to understand one brain chemical. And once you do, the rest of this video will make a different kind of sense. It's called acetylcholine, and it is, without question, the brain's most important memory messenger. Think of acetylcholine as the Wi-Fi signal between your neurons. When that signal is strong, information moves freely. You encode new memories, you retrieve old ones, you stay sharp and present. When the signal drops, everything slows down. Names disappear. Words hang just out of reach. The fog rolls in. Acetylcholine does more than just memory, though. It drives attention, it regulates your sleep cycle, it helps your brain stay flexible and responsive. It is working constantly, behind the scenes, every hour you are awake. Now here is where age enters the picture. After about 65, your brain naturally produces less acetylcholine. This is normal biology, not disease, just aging. Most people handle this gradual decline without major problems because the brain is remarkably good at compensating. But here is the critical point. Any drug that blocks acetylcholine, and there are many, hits the older brain far harder than it would hit a younger one. Because you are not starting from full, you are already working with a reduced signal. And these drugs don't just reduce it further, they jam it. This is what researchers call anticholinergic burden. It doesn't refer to one pill. It refers to the cumulative weight of everything you are taking that quietly suppresses this system. One drug with mild anticholinergic effects might be tolerable. 2 starts to compound. 3. Combined over months or years, can produce a cognitive profile that looks almost identical to early dementia. Here is what makes this so easy to miss. Several of the medications I'm going to walk you through today are not sold as brain drugs at all. They're sold for your bladder, your sinuses, your stomach, your sleep. That is exactly why they slip past everyone, including the doctor who prescribed them. So let's start with the most common one, the one sitting in more medicine cabinets than almost anything else. Diphenhydramine. You know it as Benadryl. It's also the active ingredient in ZzzQuil, Unisom, and Tylenol PM. If you have ever reached for a small pink pill to help you sleep, or grabbed something off the shelf during allergy season, there is a very good chance this is what you took. It is one of the most widely used drugs in the world, and in older adults, it is one of the most quietly harmful. Here is what it actually does inside your brain. Diphenhydramine crosses what we call the blood-brain barrier, meaning it does not stay in your body. It goes directly into your brain. And once it's there, it does exactly what I described a moment ago. It blocks acetylcholine. Directly, aggressively. This is not a side effect. This is the mechanism. The reason it makes you drowsy is precisely because it is suppressing the very chemical your brain uses to stay sharp and alert. Now remember what I said about the aging brain already running on a reduced signal. When you take diphenhydramine at 70, you are not just getting a little sleepy. You are compounding a deficit that was already there. But there is a second layer to this that most people never hear about. Think of your brain's overnight cleaning process like a night shift crew that comes in after hours. While you are in deep, restorative sleep, your brain runs a waste clearance system that flushes out toxic proteins, including amyloid, the protein strongly linked to Alzheimer's disease. This system is most active during the deep, slow-wave stages of sleep. Diphenhydramine sedates you, but sedation is not sleep. It does not reliably produce the deep, slow-wave stages where that cleaning process runs. So you are unconscious, but your brain's overnight maintenance crew never really clocks in. Over months and years of nightly use, that is not a small thing. This is what researchers call a double burden. You are blocking the brain's primary memory chemical, and you are disrupting the overnight process that keeps toxic proteins from accumulating. Both at once, every night. The research on this is sobering. Studies show a clear dose-response relationship, meaning the more cumulative exposure over time, the higher the risk. One large analysis found that long-term anticholinergic use at significant doses over 3 or more years was associated with up to a 54% increased risk of dementia compared to minimal use. Diphenhydramine is among the most common contributors to that cumulative load. I want to be precise here because precision matters. Occasional use, 1 pill during a bad allergy week, 1 dose on a red-eye flight, is a very different situation from the nightly ritual. The danger lives in the habit. In the person who has been taking Tylenol PM every night for 2 years because it's the only thing that helps them sleep. That pattern is where the risk accumulates. If that sounds familiar, there are real alternatives, and they matter for every sleep medication in this class, so I'll walk through them fully when we get there. The pill feels like the easy answer, but in this case, easy has a cost. And the problem doesn't stop with Benadryl. Now, most people who watch a video like this will already have heard some version of the Benadryl warning. So they do what seems logical. They switch to something that sounds safer. A cold and flu combination. A nighttime formula with a different name on the box. Something their doctor prescribed for itching or nerves. What they don't realize is they've often made the same trade in different packaging. Chlorpheniramine is the drug I want you to know by name. It shows up in NyQuil, in chlortrimeton, in dozens of store-brand nighttime cold formulas. It is a first-generation antihistamine, just like diphenhydramine. It crosses the blood-brain barrier just as freely. It blocks acetylcholine through the same mechanism. The anticholinergic burden it carries is not meaningfully different, and yet most people have never heard of it, because it doesn't have Benadryl's reputation. That gap between reputation and reality is exactly where the risk hides. Then there is hydroxyzine. This one is prescription only, sold under the brand names Atarax and Vistaril, and it is far more widely used than most people realize. Doctors prescribe it for anxiety, for itching, and increasingly as a sleep aid, often framing it as a gentler, non-habit-forming alternative to benzodiazepines. That framing isn't wrong exactly, but it leaves out something important. Hydroxyzine is one of the highest anticholinergic burden medications a person over 65 can take. It sits near the top of the clinical burden scales that researchers use to measure cumulative risk. And because it is a prescription drug recommended by a trusted physician, patients tend to take it consistently, often for months or years, without ever questioning it. I want to tell you about a gentleman I saw in his late 60s. His family brought him in after noticing increasing confusion and a kind of emotional flatness that had crept in over 6 months. He wasn't agitated. He wasn't distressed. He just seemed dimmer somehow, less present. His primary care doctor had started hydroxyzine about 8 months earlier for anxiety and sleep. No one had connected the two. When we carefully tapered and stopped the hydroxyzine, his family noticed a difference within weeks. His wife said it was like the lights came back on. His prescribing doctor hadn't done anything wrong by the standard of a routine checkup, but no one had stepped back to look at what the drug was doing to his brain over time. The distinction I want you to hold on to here is the blood-brain barrier. First-generation antihistamines, diphenhydramine, chlorpheniramine, hydroxyzine, cross it freely. Second-generation antihistamines largely do not. Loratadine, which you know as Claritin, cetirizine, which is Zyrtec, fexofenadine, which is Allegra. These work on your immune system without reaching deep into your brain. That difference is not a minor technical detail. For an aging brain already working harder to stay sharp, it is the difference between a safe choice and a compounding risk. But here is something most people don't expect. Some of the highest burden drugs on this list have nothing to do with sleep or allergies. They are prescribed for a completely different part of the body. Now we move into prescription territory, and into a category that surprises almost everyone who hears it. Overactive bladder is extremely common in older adults. The urgency, the frequency, the interrupted sleep from nighttime trips to the bathroom, it is disruptive, it is distressing, and it is deeply underreported because people feel embarrassed to bring it up. So when a doctor offers a solution at a routine checkup, most patients are simply relieved. They take the prescription, they fill it, they don't ask questions. The drug most commonly prescribed for this is oxybutynin. You may know it as ditropan. Tolterodine, brand name Detrol, is another. Solifenacin, sold as Vesicare, is a third. These are among the most frequently prescribed medications in adults over 65, and they belong to a drug class called bladder antimuscarinics. Here is what they do and why this matters. These drugs work by blocking the nerve signals that trigger involuntary bladder contractions. The mechanism is anticholinergic, meaning they suppress acetylcholine to relax the smooth muscle of the bladder wall. That part works. The bladder does calm down. But here is the problem. Oxybutynin, in particular, crosses the blood-brain barrier with remarkable ease. It does not stay in the bladder, it reaches the brain. And once it does, it doesn't selectively target bladder nerves. It suppresses acetylcholine throughout the entire central nervous system. Think of it this way. If the bladder is one lamp in your house, and the nerve signal is the electrical cord, oxybutynin doesn't just dim that one lamp. It dims every lamp in the house. The research here is not subtle. Long-term use of oxybutynin has been linked to significant cognitive decline, measurable brain atrophy on imaging, and reduced glucose metabolism in the memory regions of the brain, the same regions affected in early Alzheimer's disease. Among all the drugs we know carry anticholinergic burden, oxybutynin sits near the very top of the risk scale. What makes this particularly difficult is the clinical context in which it gets prescribed. A 15-minute appointment, a real quality of life problem, a straightforward solution on the prescription pad. There is rarely time for a conversation about what this drug does to the brain over 2 or 3 years of daily use. So patients don't know. And many doctors, if they're being honest, don't think to raise it. I want to be direct with you about the trade-off here, because I think you deserve honesty rather than a simple warning. Urinary urgency is not a minor inconvenience. It affects sleep. It affects confidence. It affects whether people leave the house. The goal is never to take nothing. The goal is to take the right thing. And the right thing, in most cases, is not oxybutynin. Mirabegron, sold as Myrbetriq, treats overactive bladder through a completely different mechanism. It does not block acetylcholine at all, which means it does not carry the same cognitive burden. It is a legitimate alternative worth discussing with your doctor. Trospium is another option. It is absorbed into the brain far less readily than oxybutynin, making it a meaningfully safer pharmacological choice when medication is truly necessary. And for many people, bladder training and pelvic floor physical therapy produce real, lasting improvement without any pharmacological risk to the brain. The conversation is worth having. Because trading your bladder comfort for your memory, without ever knowing that is the trade you are making, is not a choice anyone should make uninformed. The next drug category carries a different kind of risk entirely. And for many people watching this, it will be personal. The next category is one I want to approach carefully. Because for many people watching this, what I'm about to describe isn't abstract. It's a medication they've been taking for years, sometimes decades, that a doctor they trusted handed them during one of the hardest periods of their life. I want to start by saying that directly. If you take one of these medications, this is not about shame. It is about understanding what is happening inside your brain so you can make an informed decision about what comes next. Benzodiazepines. You know them as Xanax, Valium, Ativan, Klonopin. They are prescribed for anxiety, panic disorder, insomnia, and muscle tension. And they are among the most commonly prescribed medications in adults over 60 in this country. Some people have been on them for 5 years, some for 20. Here is what they actually do. Your brain has a natural braking system, a chemical called GABA, which slows neural activity down and creates a sense of calm. Benzodiazepines work by enhancing that system. They essentially press the brake pedal harder. And in the short term, they work. The anxiety quiets, the sleep comes, the panic recedes. But here is what happens with long-term use that almost nobody explains to the patient sitting across the desk. When you artificially press that brake pedal every day for months, your brain adapts. It starts producing fewer of its own natural brakes because the drug is doing the work. Over time, the brain becomes dependent on the medication just to feel baseline calm. This is not a character flaw. This is neuroplasticity working exactly as designed. Your brain reorganizing itself around the chemical environment you've created. The problem is, that reorganization comes at a cost. Research shows that chronic benzodiazepine use causes measurable structural changes in the brain. The hippocampus, the brain's memory center, shows signs of shrinkage. The prefrontal cortex, where decision-making and executive function live, is also affected. These are not theoretical risks. They show up on imaging. But the more immediate problem is what this looks like in daily life. The cognitive profile of someone on long-term benzodiazepines, slowed processing, word-finding difficulty, emotional flatness, gaps in short-term memory, looks almost identical to the early stages of dementia. I have sat across from patients who were told, or strongly suspected, that they were developing Alzheimer's disease. And what they actually had was medication-induced cognitive impairment. These are not the same thing. They do not have the same prognosis, and they do not have the same solution. This is one of the most important clinical distinctions I can offer you in this entire video, and I want you to hold on to it, because it changes what the symptoms actually mean. Medication-induced cognitive impairment, in many cases, is reversible. True dementia is not. If you or someone you love is showing cognitive symptoms and is also on long-term benzodiazepines, that connection needs to be explored before any other conclusion is reached. Now, and this is critical, I am not telling you to stop your medication. I need to say that clearly, because abruptly stopping a benzodiazepine is genuinely dangerous. It can trigger seizures. It can cause severe withdrawal. This is a medication that must be tapered slowly, carefully, and under the supervision of a physician who understands the process. What I am telling you is that you have the right to ask the question: how long have I been on this? Is there a path off? What would that look like? For anxiety that is real and debilitating, there are evidence-based alternatives, SSRIs, structured therapy, and behavioral approaches that address the root rather than suppressing the signal. For sleep, the same CBTI approach I mentioned earlier has stronger long-term outcomes than any medication in this class. The dependency is real, but so is the path forward. What surprises most people is that the drugs I've described so far aren't even the end of the list, and some of the ones left are the least suspected of all. This next part is the one I find myself returning to most often in clinical conversations. Because everything we've covered so far, the sleep aids, the antihistamines, the bladder drugs, the benzodiazepines, those have at least begun entering public awareness. People are starting to ask questions about them. What I'm about to describe, most people have never heard discussed at all. And for some of you, it will be the piece that explains something you haven't been able to account for. Let's start with proton pump inhibitors. You know these as Prilosec, Nexium, Protonix. The generic names are omeprazole, esomeprazole, pantoprazole. These are the most commonly prescribed drug class in elderly patients. Many people take them daily, long-term, for acid reflux or stomach protection, often started years ago and simply never revisited. Here is what most patients, and honestly many physicians, don't know. Proton pump inhibitors carry anticholinergic burden. In a recent hospital-based analysis, lansoprazole, the generic behind Prevacid, was identified as the single most common anticholinergic offender among elderly inpatients. Not a bladder drug, not a sleep aid, a heartburn medication. But there is a second mechanism here, entirely separate from anticholinergic burden, and it compounds the risk. Long-term PPI use blocks the absorption of vitamin B12. This matters because B12 is essential for maintaining the myelin sheath. Think of myelin as the insulation around every electrical wire in your nervous system. When that insulation starts to thin, signals slow down, misfire, or drop entirely. The cognitive effects of B12 deficiency look remarkably similar to early cognitive decline. Fatigue, brain fog, slowed thinking, memory gaps. And because both mechanisms are operating at the same time, the cumulative effect on an aging brain can be significant. If you are on a proton pump inhibitor long-term and no one has checked your B12 level recently, that is a conversation worth having at your next appointment. Now let's talk about a drug class that is still widely prescribed, often for conditions most patients don't associate with antidepressants. Tricyclic antidepressants. Amitriptyline, brand name Elavil, is the most commonly used example. Nortriptyline and doxepin are others. These older antidepressants carry some of the highest anticholinergic burden of any drug class that exists. And here is the part that matters for this audience. They are frequently prescribed not for depression, but for nerve pain, migraines, and sleep. Many patients taking amitriptyline don't even know it is an antidepressant. They were told it helps with pain, or that a low dose helps with sleep, which is true, but it is incomplete. I saw a woman in her mid-60s who had been on low-dose amitriptyline for years for migraines. She was a careful person, attentive to her health. She had simply never been told what else the drug was doing. Over time, she noticed she was forgetting more, losing words mid-sentence. She assumed it was age. It wasn't only age. When we transitioned her off amitriptyline with her neurologist's guidance, her thinking sharpened noticeably over the following months. Research supports an adjusted odds ratio of around 1.29 for dementia with tricyclic antidepressant use, and that is among the stronger associations in the entire anticholinergic literature. The third category here often surprises gastroenterologists when I raise it with them. Antispasmodic medications. Dicyclamine, sold as Bentyl, and hyoscyamine, sold as Levsin, are prescribed regularly for irritable bowel syndrome, cramping, and gut motility. They are potent anticholinergics. Most patients receiving them have never heard the term. Most have no idea there is a cognitive dimension to taking them long-term. And here is the piece that ties all three of these together. None of these drugs, taken in isolation, may be enough to push someone into serious cognitive difficulty. But when a patient is taking a proton pump inhibitor, a low-dose tricyclic for pain, and an antispasmodic for their gut, simultaneously for years, the cumulative anticholinergic burden can be severe. No single prescriber saw the whole picture. No one added it up. You may be the first person who does. Now, many people who have heard concerns about benzodiazepines have been reassured by their doctor, or reassured themselves, that there is a safer alternative, a newer class of sleep medication. Chemically different, the thinking goes, so the risks must be different too. I want to gently push back on that assumption. Zolpidem. You know it as Ambien. Ezopiclone is Lunesta. Zaleplon is Sonata. These are collectively called Z drugs, and they were introduced largely as a response to growing concerns about benzodiazepines. They are not benzodiazepines in their chemical structure. That part is true. But they work on the same receptor system, the same GABA pathway, and in particular, they act on a subtype called the alpha-1 receptor. This matters because that specific receptor is the one most closely linked to the kind of brain plasticity changes that can, over time, produce dependency and structural adaptation in the aging brain. In other words, a different key, but the same lock. And then there is the sleep quality problem, which mirrors what I described with diphenhydramine, but through a different route. Z drugs produce sedation. They do not reliably produce the deep, slow-wave sleep that your brain needs to run its overnight maintenance. That night shift cleaning crew I mentioned earlier, the glymphatic system that flushes amyloid and other toxic proteins, it depends on genuine restorative sleep to do its work. Sedation is not the same thing. You may feel like you slept. Your brain may not have had the deep, slow phases where the real cleaning happens. Over years, that distinction accumulates. The data here is difficult to set aside. A large study out of UCSF, following roughly 3,000 older adults over 9 years, found that frequent prescription sleep aid use, including Ambien, was associated with a 79% increased dementia risk in one demographic group over that follow-up period. That is not a small signal. There is also a pattern I see regularly in clinical practice that functions as its own warning sign. Someone starts Ambien at a low dose. After a few weeks, it stops working as well. The dose goes up. Or a second medication gets added. That escalation, that quiet negotiation with tolerance, is the brain reorganizing itself around the drug. It is the same adaptive process I described with benzodiazepines, operating through the same receptor family. What I want you to understand is this. Most people taking Z drugs are not doing so carelessly. They are doing so because they have a real problem, insomnia, that genuinely disrupts their health, their mood, and their function. That problem deserves a real solution. A chemical workaround that compounds over time is not that solution. CBTI remains the strongest evidence-based treatment for chronic insomnia. It addresses the actual patterns keeping you awake rather than just suppressing the signal, and its outcomes outlast any medication by a significant margin. Low-dose melatonin, and I mean genuinely low dose, between 0.5 milligram and 3 milligrams, works with your brain's natural sleep timing rather than overriding it. Magnesium glycinate is a well-tolerated companion to that approach. If medication is genuinely necessary, very short-term use, days, not months, with a clearly defined endpoint is the clinical standard. The goal is sleep. Real sleep. Not just unconsciousness with a name-brand label on the bottle. But here is something I want you to sit with before we go further. Addressing the medications is one part of this, and it is an important part. But there is something else quietly working against your brain, something most people are consuming every single day that can undo much of the progress you make by fixing the medication side. It is not a pill, and it is not what most people expect. So we have covered a lot of ground. Sleep aids, antihistamines, bladder medications, benzodiazepines, proton pump inhibitors, tricyclic antidepressants, antispasmodics, Z drugs. If you are sitting with some discomfort right now, that is appropriate. But I want to make sure that discomfort moves you toward a conversation, not toward panic, and not toward stopping anything on your own. Let me be clear about what I am not asking you to do. I am not asking you to stop your medications today. For several of the drugs we discussed, benzodiazepines especially, and antidepressants, abrupt discontinuation is genuinely dangerous. That is not a path you take alone. Any reduction needs to be slow, supervised, and deliberate. What I am asking you to do is become an informed patient. Someone who walks into the next appointment with a list and a specific question. Here is the practical step, and it is simpler than most people expect. Before your next visit, write down every single medication you take. Prescription drugs, yes, but also every over-the-counter pill, every supplement, every as-needed medication you reach for during the week. The sleep aid you take 3 nights out of 7. The antacid you've been on for 2 years. The allergy pill you keep in your purse. All of it. Then bring that list to your doctor or your pharmacist and ask this specific question. I've been reading about anticholinergic burden. Can we look at my list together and see where I stand? That phrase, anticholinergic burden, is a real clinical term. It is not fringe language. There is a validated scoring tool called the ACB scale, the anticholinergic cognitive burden scale, and your pharmacist or physician can use it to calculate your cumulative score. This is a legitimate request. You are entitled to make it. Now, I want to address something honestly because I think you deserve that. For mild cognitive impairment, the kind of fog and slowing that hasn't yet crossed into dementia, reducing anticholinergic burden can produce meaningful recovery. I have seen it. The woman I described at the beginning of this video is one example among many. The brain, when given the chance, is remarkably resilient. For more advanced dementia, the picture is less clear. Stopping further harm is always worth doing, but the reversal of significant structural damage is not guaranteed. This is why the timing matters. The earlier this conversation happens, the more options remain open. I also want to acknowledge something about the reality of getting older in a medical system that is stretched thin. Many of you are seeing multiple specialists: a cardiologist, a urologist, a gastroenterologist, a primary care doctor. Each one sees their piece of the picture. None of them may be looking at the whole. You may be the only person in your own care team who has visibility over everything you are taking. That is not fair, but it is the reality, and it means you may need to be the one who connects the dots. You are not being difficult by asking these questions. You are being your own best advocate. And in this case, advocacy is protection. So here is where I want to leave you. You now understand something that many people your age, and many of their doctors, have never pieced together. You know what anticholinergic burden is, why it accumulates invisibly, and how to start a real conversation about it. That is not a small thing. That is protective knowledge, and it is worth acting on. Write down every medication you take before your next appointment. Prescription, over-the-counter, as needed, all of it. Then bring that list in and ask specifically, can we look at my anticholinergic burden together? That one question can change the direction of a conversation, and sometimes the direction of what comes next for your brain. But I want to be honest with you about something. Reducing the medications that block acetylcholine clears an important obstacle. Your brain gets a chance to recover signal it had been losing. That is real, and it matters. What I see in patients who do this work, though, is that the ones who protect those gains most effectively are the ones who also address what is feeding the inflammation and metabolic stress that ages the brain from the inside. And the most common source of that, the one that works quietly, daily, without any label warning you, is something most people would never think to connect to memory. That is exactly what the next video is about. I want you to watch it now, while this is still on your mind. Because the two pieces fit together, and if you only fix one, you may be leaving the other one running unchecked. The video is right there on your screen. It is the next step. And for anyone who has already started taking their medication review seriously, it is the one you do not want to skip.